A warm good morning to judges and my dear colleagues. I would like to present my thesis work on long-term outcomes of ciliary sulcus placed Ahmed Glaucoma wall in refractory glaucomas of Indian eyes under the guidance of Dr. Devang, Professor Tanuj and Professor Vinay Gupta, and the study has been done in our center, RP Center. And as we all know, refractory glaucoma is uncontrolled intraocular pressure despite maximally given medications and non-seton surgical procedures, so in a combination of the both. And those which are at high risk of failure for further trabeculectomy. And in literature, we have seen the TVT study, the tube versus trabeculectomy study, at the end of 5 years had a cumulative probability of failure was 30% with the tube group versus around 50% with the trap group. Then it was known that GDDs seem to be promising for refractory glaucoma, but where are GDDs, AJV is one, AJV is usually traditionally put in anterior chamber, but what's the challenge with anterior chamber placement of AJV? Corneal decompensation and corneal related complications account for around 7 to 27% of complications in the literature. So what's the alternative? The alternative is we have two more paths. We can put it in ciliary sulcus or the pars plana route. What's the challenge with pars plana route? You go into the posterior segment, you have posterior segment complications and more vitrectomy need and inflammation. So it was already priorly established that it is advantageous to perform a ciliary sulcus among these three routes. However, we don't have any long-term ciliary sulcus AGV studies in Indian population, and especially the micro level. At the micro level, endothelial cell count changes is not established in Indian eyes. Okay, the aim of the study to evaluate long-term efficacy and safety, primary objectives being a reduction of IOP, reduction in number of medications, and longitudinally assess the endothelial cell density changes. Secondary objectives being long-term complications, and we also parallelly studied bleb morphology on anterior segment optical coherence tomography. We took a sample size of 15 eyes of 15 patients, and it's a prospective study. Inclusion criteria being 18 to 85 years of age and diagnosed case of refractory glaucoma, and no prior AGV or any tube surgery was done. And we have excluded the pregnant patients and pediatric patients. And our success criteria was IOP more than 5 and less than 21 millimeter of mercury, and around 20% reduction in IOP with no loss of perception of light and no need of any secondary surgery for the complications. Results, we have done 15 patients and mean age being around 30 years and length of median follow-up was 13.5 months. Clinical history, we have these primary diagnoses, most common being PCG or developmental glaucoma, which failed by the age they reached 18 or more, and there are 3 patients of this, and 2 each of silicone oil-induced traumatic and post-keratoplasty patients, and the rest are secondary glaucomas, including Ice syndrome, uveitic and Sturge-Weber syndrome, and complicated pseudophakia. So systemic history, none of our patients had any systemic history, and except one patient is positive for HLA-B27. Coming to the results, the significant reduction in IOP, nearly 49% from 33 mmHg to 16, and is statistically significantly reduced. And medications, number of medications were reduced from 5 to almost 0.92. And these are Kaplan-Meier analysis for survival, and the cumulative probability of success was 83% at 6 months, and 77% at 1 year, and 71% at 2 years. So some of the complications we faced are all the minor complications with ciliary sulcus place. 2 of them had bleb encapsulations, and one of the patient, the one which I taught HLA-B27 positive, had an inflammatory membrane which got relieved spontaneously on starting her on QID dose of steroids, and one patient had a hyphema. There's one more issue which we encountered is most often when we place sulcus IOL, the tube gets misdirected behind the IOL, at times clogged with vitreous, but we need to reposition the post-op next day. So the one more, coming to a secondary objective, we studied bleb morphology and anterior-segment OCT. We took a bleb height, bleb thickness, and homogeneity of the bleb to learn about them. These are serial follow-ups at 3 months, 6 months, 9 months, and 12 months. It was not a statistically significant result, but however, we concluded, we came to know that clinically thinner blebs were noted at the early follow-up, be it 3 and then 6 rather than later. We also used AIOCMTC2 as a tool whenever we had a doubt what is a successful bleb or which is going into encapsulated. Successful bleb, as you can see, there is homogeneously described well uniform bleb. However, encapsulated had thicker bleb walls, irregular bleb wall, and high voluminous bleb. So at a point when 4 to 6 months, whenever we had a doubt whether to go for a bleb needling or capsulectomy for the encapsulated blebs, we always use this tool or whether to continue topical medications. Coming to our primary objective, again, endothelial cell loss, we could make out 4.35% reduction in at 6 months and 7.12% reduction in at 12 months. This is compared to the literature study which showed Andresulcus had 9%, 9.5% at 6 months and around 12.5% at 12 months. It's the work by Kim et al. Published in BMJ in 2016. They also published the cell loss in trabeculectomy, which is 1.5 and around 3 at 6 and 12 months. So I would conclude there is the success rate and for nearly 50% reduction of IOP and clinically relatively thinner blebs. And I would acknowledge my mentor and guide, Dr. Devang, Professor Tanuj, and Professor Vinay, and my alma mater, RP Center, and last but not least, my patients.
So AGV was the only type of tube used?
Yeah, ma'am. In this only AGV was used and it was FP7.
FP7 in all cases?
Yeah, ma'am.
All right. And all your patients had trabeculectomy before?
Yeah, ma'am. Yes, ma'am, they are failed traps. I defined refractory glaucoma then itself, whatever diagnosis I have taken, they have failed trabeculectomies more than 2 or 1.
Even the secondary glaucomas, they
Yes,
had traps before?
Yes, ma'am.
Okay. Where did you target your endothelial cell count?
Ma'am, it wasn't localized, but more often near the tube. More often we placed it at superior temporally, the AGV tube. Near the superior temporal, we took the specular counts.
So do you think one region like that, where you have a foreign body there,
yeah,
and expect a reduction, do you think just taking in one quadrant gives you
adequate
information?
I do get it, ma'am, but the losses for the corneal endothelial cell count is not just the target area. Whenever the patient moves the eye or forceful rubbing, the tube is moved in and more. And even the opposite area, superior nasal, inferior nasal, the gush of the fluid from the aqueous gush versus the heart rate or pulse is also related in literature. So it showed that these are the reasons for endothelial cell loss. It's not just superior temporal quadrant. There is one limitation. We just compared one area. I do agree, but diffuse we couldn't take because most of the patients had post-traumatic, post-keratoplasties where we couldn't capture the specular counts.
So there were patients where you could not capture?
Yeah, ma'am, I did mention only 10 patients we could, out of the 15, I could only mention 10.
Okay. Thank you very much.